Good morning, good evening to all of you. Welcome to the second episode of the Autoimmune Nephrology webinar series hosted by the Euroimmune Academy. My name is Maite Zabalza and I am the Scientific Affairs Manager at Euroimmune US. Today, we are discussing a well-known topic, the role of PLA2R testing in pre- and post-renal transplant monitoring in membranous nephropathy. Similar to previous webinars, we will start with a presentation from our speaker, and towards the end, we will have a panel discussion. If you have any questions, please type them in the chat box on your screen, and we will relay them to the speaker at the end of the presentation. Any unanswered questions will be addressed via email. Without further ado, it is my pleasure to introduce to all of you our speaker, Dr. Jim Francis. Dr. Francis is an associate professor of medicine and the founder of the thrombotic microangiopathy team at Boston University Medical Center. Dr. Francis obtained his medical degree from the Lebanese University School of Medicine and completed his medicine residency and nephrology fellowship at the Hospital of Saint Raphael and Yale University. Subsequently, Dr. Francis did a kidney and pancreas transplantation fellowship at Beth Israel Medical Center and Harvard Medical School. Currently, Dr. Francis is the medical director of the kidney transplantation at Boston University Medical Center and serves as the medical director of the pancreas transplant program at Brigham and Women's Hospital. Dr. Francis also conducts clinical research in kidney transplantation and has a special interest in thrombotic microangiopathy, complement-mediated diseases, and recurrent glomerulonephritis after kidney transplantation. In addition to this, Dr. Francis is an accomplished educator who has won several excellent in teaching awards from the Department of Medicine. Welcome, Dr. Francis. I will pass it over to you to begin your presentation.
Thank you so much, Maite, for this nice introduction. And thank you for Euroimmune for organizing this webinar. And I would like to thank all the people attending from all over the world, it seems, many places. I will now share my screen and start with my presentation. So today I will be discussing membranous nephropathy post-transplant. We'll focus on the recurrent membranous nephropathy and touch a little bit on the de novo membranous nephropathy, but I will be also discussing at length the role of PLA2R testing in the pre and the post-renal transplant monitoring of recurrent membranous nephropathy. To begin with, primary membranous nephropathy is one of the most common causes of nephrotic syndrome in adults. It is an autoimmune disease of the kidney. And membranous nephropathy is present in 15 to 33% of the kidney biopsies performed for heavy proteinuria. And it is characterized by glomerular basement membrane thickening with minimal or absence of cellular proliferation. It is not an inflammatory glomerulonephritis. There are deposits and there are leaky glomeruli, and we'll discuss further on the next few slides. So it is primary or idiopathic. It used to be called idiopathic. Now with further identification of many different antigens, essential one is anti-PLA2R. So we know that it is a primary form of membranous nephropathy, is the most common form. It constitutes close to 80% of the membranous nephropathy diagnosed by kidney biopsy. Membranous nephropathy can also be secondary to infection, drugs, toxins, autoimmune diseases, and cancers, and the secondary form constitute close to 20% of the cases of membranous nephropathy. Primary membranous nephropathy is distinguished from the secondary forms by its predominant IgG4, absent C1q, but there is abundance of C3 deposits on the kidney biopsy tissue. Those are the different stages of membranous nephropathy as seen on electron microscopy. Early on, deposits will be located in the peri-slit area. And at that stage, patients can be diagnosed with early biopsy, and by looking under the electron microscope, you can see those deposits at, at under the slit diaphragm. At that stage, patients could be symptomatic with proteinuria or even asymptomatic, depending on how much disruption in the slit diaphragm there is. As the deposits progress and more accumulate, they start invading into the glomerular basement membrane. On stage 2, this constitutes stage 1. Stage 2, you can see spikes from the basement membrane trying to circle those deposits. And then those deposits in stage 3, with further activation and thickening of the glomerular basement membrane, they get engulfed into the glomerular basement membrane. And later on, either with remission of the disease or after treatment and response, or even just because of long time deposition, they get degraded, those deposits, and you start see those loosened intramembranous membrane, suggesting an old deposited material. So those are the different histological stages that we can track on electron microscopy of primary membranous nephropathy. The same could exist also in the recurrent membranous nephropathy when it is left on its own, untreated. So primary membranous nephropathy has variable clinical course. It can result in spontaneous remission in 30 to 40% of the time. It can lead to persistent proteinuria in 30 to 40% of the time, or it could lead to progression to end-stage renal disease in 15 to 30% of the time. There are some risk factors that suggest high propensity of progression. One is age. Elderly have higher risk of progression. Severe proteinuria of more than 8 grams per day for more than 4 to 6 months also suggests higher risk of progression. Male sex and elevated creatinine at time of presentation, suggesting an AKI associated with a nephrotic syndrome, all are signs of higher risk of progression. And the tissue biopsy also could be very informative. If you have advanced tubulointerstitial fibrosis on the kidney biopsy, all of that portend higher risk of progression and worse prognosis. So the antigen that is mediating the membranous nephropathy has remained elusive for many years. In the late 70s, early 80s, research group from Boston University, the institution where I work, and also groups from Europe were able to kind of confirm that the mechanism of pathophysiological injury in membranous nephropathy results from an autoantibody attacking or binding to an antigen expressed on the podocyte, leading to those deposits that we see. So in the animal model, this came from confirmation from animal model like the Hayman nephritis. We know that megalin that is expressed on the podocyte could be targeted by an antibody, and then it sheds into the subepithelial space, and down the road it fills into the glomerular basement membrane, leading to the membranous nephropathy in a rat model. So, but the antigen in the human disease remained very elusive for many years. As we know, megalin is not expressed on the podocyte until a major breakthrough happened in 2009 from the group at Boston University led by David Salant and Larry Beck, where they identified phospholipase A2 receptor, which is a protein or a receptor expressed on the podocyte, as the dominant target antigen in idiopathic membranous nephropathy. So now we call it primary membranous nephropathy, or even PLA2R associated membranous nephropathy. With elegant experiments, they were able to see that patients with membranous nephropathy, their sera binds to a special band at 185 kilodalton. So this band, with further mass spectroscopic analysis, they were able to know that this protein here is the PLA2R, or the phospholipase A2 receptor. This is the band in its glycosylated form, but the same antibody from the same patient interact with a deglycosylated form of this protein at 145 kilodalton. They were able to show that this antibody, anti-PLA2R antibody, is very specific for idiopathic membranous nephropathy. It was not present in any patient with secondary membranous nephropathy or other disease or normal control. And they were able also to show that the IgG4 is the dominant form of IgG, in the sera of those patients. So none of the diabetes patient or FSGS patient or here another diabetes patient had interaction with this band, suggesting the high specificity of this antibody. Then they were able to stain for the deposits, and they showed that PLA2R is within those deposits in the pericapillary subepithelial space. The IgG4 is also in the same deposits, and when they did the merge, you can see they overlap nicely, suggesting that those deposits we see in primary membranous nephropathy are combinations of IgG4 and PLA2R. Many studies from us, from Minnesota, from the Netherlands, from Sweden, China, and many, many other studies confirm the high specificity of PLA2R for the idiopathic form of membranous nephropathy. Now we call primary or PLA2R associated membranous nephropathy. And in most of those studies, secondary MN patients, disease control and normal controls had no expression of anti-PLA2R, suggesting a high specificity of anti-PLA2R for this idiopathic MN. Some reports reported or showed the presence of anti-PLA2R in some cases of membranous nephropathy related to sarcoidosis, liver, autoimmune disease, hepatitis B, especially from the Chinese cohort. But it is really thought that this represents an overlapping of two or more diseases rather than association. Everybody now believes, all the experts believe that anti-PLA2R is very specific to primary membranous nephropathy. So what is PLA2R? It is a member of the mannose binding receptors. It contains several SNPs in the region of the anti-PLA2R epitopes. And then a question was posed and asked, could any of those SNPs predict high recurrence, high risk of developing membranous nephropathy? A landmark study from the UK was able to show that patients who are homozygous for this particular SNP in the PLA2R alleles and homozygous for those particular SNP in the HLA-DQA1 alleles, they have 80 times higher risk of developing membranous nephropathy. So it became clear that patients with membranous nephropathy have some genetic predisposition. And then another trigger, which could be environmental, could be infectious, could be drug, or anything else that remains, pollution, whatever has been studied so far, in addition to this genetic background, could predispose patient to develop membranous nephropathy. Other multinational genome-wide association studies identified other associations with HLA-DRB1, DRB3, NF-kappa B1, and IRF4. So we know that there's genetic background for this disease, and superimposed are some triggers from the environment. Not all negative anti-PLA2R sera are not anti-PLA2R mediated membranous nephropathy. You could kind of increase your sensitivity to detect PLA2R by staining the tissue biopsy for PLA2R. And in this study by Debiak and Ronco, you can see that only 57% of their patients with membranous nephropathy had positive anti-PLA2R in the serum, but 74% of those patients were able to show deposits of PLA2R in their kidney biopsy. So if your patient is negative in the sera, make every effort to stain the biopsy to fully rule in or rule out the possibility of PLA2R mediated membranous nephropathy. So the absence of circulating PLA2R antibodies or autoantibodies at the time of kidney biopsy does not rule out a diagnosis of PLA2R related membranous nephropathy. Stain the kidney biopsy for PLA2R. So it didn't take a long time after the specificity of this antibody has been very well defined and this antigen for the disease for Euroimmune to develop two commercial tests that are currently approved by FDA to detect anti-PLA2R. The first test is an ELISA test, which is very useful for the initial detection and reports titers. So values less than 14 units per ml are considered negative, but it remains to be defined. If you have a value between 2 and 14, it could represent low levels, and further confirmation is needed. Further confirmation can be done by either Western blot and very specialized labs, or by immunofluorescence test, which uses transfected cells for recombinant PLA2R. It is more sensitive than the ELISA test and only give you semi-quantitative levels of the antibody, 1 over 10, 1 over 100, 1 over 300. And then, it was a cascade of discoveries of many different antigens. As you can see, PLA2R remained the dominant one. It is positive in 65 to 70% of primary membranous nephropathy, and it is not associated with anything except the idiopathic form of the disease. So it's very specific. Then 7A protein, NEL1, and many others were discovered. And as you can see, they have different associations, some with malignancies, some with membranous lupus nephropathy, especially the exostosin 1 and 2, or the TGF-BR3. Every day, every week, there's a new antigen that is being described. I should also let you know that 7A can be tested by the Euroimmune labs. So many antigens are being discovered, but PLA2R remains the dominant one. So what about post-transplant membranous nephropathy? It could be either a recurrence of primary membranous nephropathy. This is the same autoimmune disease that caused the native kidney disease, or it could be a de novo membranous nephropathy. Most of the time, this is an alloimmune disease. It could be a recurrence of secondary membranous nephropathy, such in the case of lupus nephritis. This is uncommon. Or it could be a membranous nephropathy associated with chronic graft versus host disease after allogeneic stem cell transplantation. And yesterday, I think it was just released that the antigen specific for this form of membranous nephropathy has been discovered by the Mayo Clinic group. So what about the incidence of recurrent membranous nephropathy? The incidence of recurrence is 10 to 45%. So it is high in centers performing protocol biopsies. They will report higher incidence and earlier recurrence. In a study, 19 patients with membranous nephropathy underwent surveillance biopsies after transplantation. Recurrent membranous nephropathy was detected in 8, which is 42% of the patient. And the median of recurrence was 4 months with a range 2 to 61 months. 3 patients had no proteinuria despite having deposits identified on protocol biopsy. This is why you could have such a high level of recurrence depending on the method. If you wait for the clinical manifestation, probably you will report lesser incidence of recurrence. Recurrence is usually linked to the same antibody that caused the native membranous nephropathy. If this is a PLA2R membranous nephropathy, it will recur with a PLA2R or 7A, etc. So this is very important for us to know because you can detect those antibodies prior to transplant and monitor them after the transplant to guide you on when to biopsy or give you an idea how the patient is evolving. So what are the risk factors for recurrence? Initial reports suggested that patients with living-related donor transplants are at higher risk for recurrence than those who receive a deceased donor graft. This has not been supported by all the studies. And I should emphasize here that if you have a patient with membranous nephropathy who has a live donor, you should proceed with the transplant because the benefits of the transplant outweigh by a lot the risk of recurrence. Other risk factors for recurrent membranous nephropathy are high level of proteinuria pre-transplant, suggesting active disease. So if you let the disease become a bit more quiescent, the risk is lesser for it to recur. Very low albumin also suggests a heavy proteinuria in the native kidneys and active disease, and it could also pretend a high recurrence rate. Shorter wait on the list time and circulating anti-PLA2R are also risk factors for recurrence, especially if the anti-PLA2R titers are high, and we will discuss that later on in this talk. So what is the risk of graft loss from recurrence? Among 81 renal transplant recipients with membranous nephropathy, allograft loss from recurrent membranous nephropathy at 10 years follow-up was 12.5%. It's not high, thankfully, but it's substantial. Among 28 kidney transplant patients, risk of death censored graft loss over 50 months was 10%. And in one study, the risk of graft loss after transplant in membranous nephropathy patient compared to PKD recipients was almost double, and it was attributed to recurrent membranous nephropathy. So there's some risk of graft loss. It's not terrible, and it's treatable, and hopefully with treatment we can reduce this risk. When the disease recurs, it also recurs with a dominant or a codominant IgG4, similar to the native kidney membranous nephropathy. Interestingly, the pathology of the recurrent disease is a bit different from the native kidney pathology. Here, you have the thickening of the basement membrane. You can see the deposits and some spikes around them. Here, you can see that there is abundant C4D positivity on the kidney biopsy and abundant C4b positivity. The IgG is an IgG4, and there is minimal to absent C3. So native kidney biopsies have a bright C3 staining. Recurrent membranous have minimal to absent C3, but abundant C4D and C4b. So probably there is a different C3 regulation and activation in native kidneys as compared to transplant kidneys. So what is the rationale for studying anti-PLA2R in recurrent membranous nephropathy? We know that early recurrence leads to rapid progression and worse prognosis after transplant. So knowing if the circulating factor, which is in 70 to 80% of the time an anti-PLA2R, is present at time of transplant is very important to guide you how to prep your treatments or how to be prepared for any risk of recurrence. We know that early treatment with rituximab is effective in inducing remission, partial or complete, in membranous nephropathy in native and transplanted kidneys. So PLA2R could also play a role as a guide to tell us if we are responding to the treatment. And the reason for that is that rituximab-induced remission in native kidneys correlates with a decline in anti-PLA2R, and the same has been described with recurrent membranous nephropathy. In a native kidney study, I will show you here 25 of 35 positive anti-PLA2R patients. 17 of those 25 had decrease or disappearance of anti-PLA2R after rituximab. This is close to 70%. The disappearance of anti-PLA2R was associated with complete or partial remission in 60% of the patient at 1 year and in almost 90% of the patient at 2 years. Persistent anti-PLA2R led to complete remission or partial remission in no patients. And at 1 year, only 33% of the patients showed some partial or complete remission. So anti-PLA2R might help to follow and predict response to treatment with rituximab. Importantly, also you can see here that by the time anti-PLA2R disappears, let's say at 9 or 12 months, patient will continue to have some proteinuria. So there is an initial immunological response followed later on by a clinical response. Proteinuria might take longer to decline because the kidney needs to clean out all those deposits, and sometimes there are some scarring that could lead to persistent low level of proteinuria. So we all agree that the same pattern also exists in the treatment after treatment of recurrent membranous nephropathy. Also, again, to highlight this delay of the clinical remission as compared to the immunological remission. So, the anti-PLA2R start developing, they sink into the kidney, they get absorbed in the kidney. So a certain period when PLA2R are being produced, they might not be detectable in the serum. When the kidney is saturated, then you can start detecting the anti-PLA2R in the sera, and this also at the same time, kidney will start developing some degree of proteinuria. Then there is a period of overlap where PLA2R is very positive and proteinuria is high. And then either you treat or there's a spontaneous remission where anti-PLA2R disappear, but proteinuria will persist until these deposits are completely cleaned and removed, and hopefully there is no scarring in the kidney, then proteinuria will completely go. So keep in mind that PLA2R disappearance precedes the clinical improvement in proteinuria or kidney function. So is recurrent membranous nephropathy in transplant human kidneys associated with circulating anti-PLA2R? So do we have an evidence if somebody has anti-PLA2R at time of transplant that he's going to recur? The first case report after the publication of anti-PLA2R antibody by the Boston University group came from Germany. And you can see here a patient who had very high levels of anti-PLA2R just before the renal transplant. He got a kidney transplant, and then a few weeks after, or days even, he started developing some proteinuria. Then they tested him. He was still positive for anti-PLA2R despite the induction therapy, despite the immunosuppressants used for the kidney transplant. And then his proteinuria became more severe. Then they gave him a dose of rituximab, another dose of rituximab after 2 weeks, and you can see the PLA2R level drop, but the proteinuria persisted, and we know that. PLA2R continued to drop, and then later on, proteinuria started to improve, and the patient did well. So this was the first evidence to show that if you have the antibody, the risk of recurrence is high, but if you treat and eliminate the antibody, remission could follow. This is a case from our university, from our practice here. Our patient in 2004 had membranous nephropathy on his native kidneys. By 2007, he developed end-stage kidney disease. In April of 2010, he received a living-related kidney transplant from his sister. And few days or weeks after his transplant, he developed proteinuria. We did a biopsy, and the allograft showed recurrent membranous nephropathy, and I'll show you the slides in a second. So we gave him rituximab 4 doses, every week a dose, and his PLA2R was so stubborn, remained positive despite all the rituximab, and his proteinuria continued to rise and reach almost 5 grams. And then we repeated a biopsy, and I'll show you. This is his native kidney biopsy showing those subepithelial deposits. This is the early biopsy we did post-transplant. You can see you only can identify those deposits in the peri-split area. There's nothing yet here, but after almost few months, you can see there's abundant, despite rituximab treatment, you can see the abundant deposits in his kidney. So he remained PLA2R positive for almost 2 years, and only it took him close to 2 years for the PLA2R to become undetectable. Unfortunately, he had kidney injury and kidney damage, and the creatinine, deteriorated. This is a study by Hannah Debiak and Pierre Ronco from France. They had 10 cases of recurrent membranous nephropathy. 5 of those cases were PLA2R mediated. 4 were positive at or before transplant, and 1 was positive at time of recurrence. And all those patients stained positive for PLA2R on the kidney tissue biopsy. The other 5 cases they had no PLA2R, and none of them stained positive in the kidney biopsy for PLA2R. Interestingly, they showed that anti-PLA2R was absent in all 9 cases of de novo membranous nephropathy studied at the same time. So we know that de novo membranous nephropathy is not PLA2R mediated. 3 patients in their group in this study had positive anti-PLA2R but did not recur. And we will discuss a little bit why could this happen. So the question is, does a positive anti-PLA2R at or just before transplantation predict recurrence, and what is the percentage of recurrence? And can one use anti-PLA2R seropositivity post-transplant instead of surveillance biopsies to diagnose early recurrence? This study from the Mayo Clinic included 63 patients with membranous nephropathy who got a kidney transplant. 30 of those patients had recurrence, and of those 30, 13 had no clinical progression, and 7 cases had no clinical progression, and 2 had no progression in short follow-up, 3 were lost to follow-up, and 1 expired. But 17 of those 30 patients who recurred required the treatment, so 9 had complete response, 5 had partial response, and 3 had no response. Let's look at the patients and their PLA2R levels at the time of transplant or after recurrence. So 30 of those 63 patients with membranous nephropathy who got kidney transplant had an anti-PLA2R checked pre-transplant. 18 were positive anti-PLA2R, and of those 18, 14 had a recurrence, 4 did not recur. So they were positive but did not recur. 12 had no anti-PLA2R. They were negative for anti-PLA2R, and only 4 of those 12, 33%, had recurrence, versus 80% of the PLA2R positive had recurrence. So from this data, based on those 30 cases with positive with available testing, you can tell that the positive predictive value of anti-PLA2R to predict recurrence is close to 80%. So in patients with positive tests at time of transplant, there is 75 to 80% chance of recurrence, but 20% have not recurred for up to 9 years despite positive anti-PLA2R. If the test is negative for anti-PLA2R, there is a chance of 30% recurrence, mediated probably by other antigens we know or we don't know. So interestingly, also from the same data, anti-PLA2R at time of transplantation, if it was strongly positive, the recurrence is happens very early, and this is important for us to know because probably those people will require preemptive treatment before transplantation if they have such a high risk of recurrence and early recurrence rate. And if you have low levels or you are negative for PLA2R, the recurrence usually takes longer to happen, close to 800 days for it to happen. And there was no difference between living-related, living-unrelated, or deceased kidney transplant, although I told you that there are some data suggesting that living-related kidney transplant has higher risk of recurrence, but this has not been shown in this study. So what about the false positive and negatives? So if you are anti-PLA2R positive, but you do not recur, why is that? Probably the immunosuppression that you are taking at time of transplant may alter the pathogenicity of the autoantibody and you don't recur. Probably, and this I think is very important, there's a different genetic polymorphism in the recipient as compared to the donor, which could alter the antigen presentation and render those antibodies ineffective to bind. Second, HIT may be necessary to create a pathogenic conformation in the donor PLA2R, which could or could not happen at time of transplant. So what about the people who recur despite negative anti-PLA2R? This disease might be mediated by a different target antigen, 7A, or the other antigens that I just showed you before, or that the anti-PLA2R may be in the glomeruli but no longer in the serum. So do not forget, when you biopsy patient with membranous nephropathy, if you have undetectable anti-PLA2R in the blood, make sure you stay in the kidney biopsy for PLA2R to confirm if this disease is PLA2R mediated or not. So can we prevent graft loss from recurrent membranous nephropathy? So identify and treat recurrent cases early with anti-CD20, which we think is the treatment of choice. Monitor cases with pre-transplant anti-PLA2R closely for proteinuria. Anti-PLA2R negative cases require surveillance biopsies as well as proteinuria monitoring. And biopsies should be stained for PLA2R. And we still need, as practitioner, to develop protocol for post-transplant serum monitoring for anti-PLA2R. So KDIGO has some plans, some publications have some protocol. I will briefly discuss that in my talk. So does rituximab work for the treatment of recurrent membranous nephropathy? In this case series from the Mayo Clinic, 8 patients had recurrent membranous nephropathy. And when they gave them rituximab, 50% of them either had complete or partial remission at 4 months. 2% of them had either partial or complete remission by 12 months, and close to 90% of them had complete or partial remission by 24 months. So rituximab worked. What about the study from Mayo Clinic that I showed you before? You can see they had 63 patients with primary membranous nephropathy and underwent kidney transplant. 30 of those patients had histological recurrent membranous nephropathy, but only 50% of those recurrent had clinical manifestations. Rituximab in this study was given to patients with proteinuria of more than 1 gram per day. 82% of them had either partial remission or complete remission. 40% had histological remission and with no relapse after 15 months of follow-up. So this is why we think rituximab is the treatment of choice for recurrent membranous nephropathy. I want to alert you to the fact here that 30% of the patients who recurred had either spontaneous remission or no progression, exactly what we see in the native kidney. and 82% of the people who were treated for a proteinuria equal or more than a gram per 24 hour entered either partial remission or complete remission. So the benefits from rituximab appear to be higher and last longer in recurrent membranous nephropathy as compared to native kidney membranous nephropathy. Probably this is related to the fact that they are already on other immunosuppressants that could alter the function of the T cells, and this could support further, a suppression of the activity of B cells. And this is why probably they have a better response after treatment with rituximab. So to summarize, treatment of recurrent membranous nephropathy, there should be a rigorous blood pressure control, preferentially with ACE ARBs, and now people talk about SGLT2, although their safety in transplantation remains to be defined. You should use statins, anticoagulation if there's severe hypoalbuminemia and high risk of DVTs, vitamin D supplements, whatever, all what you use to treat nephrotic syndromes. Rituximab is the preferred immunosuppression if you are to use any immunosuppressive therapy. There are limited evidence to support that because all it's based on case series, and it's still a big debate about how to dose it and how much to give. Some people consider Cytoxan, although it's a bit more toxic in transplant population, and you have probably to stop anti-metabolites if you decide to use Cytoxan. And there are questionable role of plasmapheresis to remove those circulating anti-PLA2R. So KDIGO, with the availability of anti-PLA2R now, they have kind of protocolized how to prepare patients for kidney transplantation if patients have membranous nephropathy. So they ask us in the pre-transplant evaluation to make every possible effort to ascertain if this membranous nephropathy is associated with PLA2R or not. So they want us to know the PLA2R status of the patient pre-transplant, and if it is known that it is PLA2R mediated, or if it is unknown, they want us to measure PLA2R antibody before transplantation. So if the patient is negative for PLA2R, they ask us to retrieve the native kidney biopsy. And if the biopsy is positive and the antibody is undetectable now, it seems that the antibody has disappeared, then there is a low risk of recurrence close to 10%. But if we know that this biopsy and everything rules out the link of PLA2R to this case of membranous nephropathy, there is a medium risk of recurrence close to 30%, as I showed you before. So if the patient is positive, KDIGO here says there's a high risk of recurrence of 50%, and I showed you in some studies can go up to 80%, depending probably on the level and other predisposing factors. So it's a high risk of recurrence. So how could we prevent that, and who should we prevent that? I like this algorithm from paper by Leon et al. Published in Transplantation, and I want to just show you this part of this paper. So if you have a PLA2R associated membranous nephropathy, they recommend to consider preemptive rituximab for induction in case of high risk of recurrence, and they call high risk of recurrence high anti-PLA2R titer. So for me personally, this is what we do in our transplant program, and we consider high level, any level of 150 and above by an ELISA test. So what would you do with somebody who's 120 or 90? It's I don't have a good answer for that. It depends on your patient. If you want to take the risk or you want to pre-treat, I don't have any really good suggestions here. And if the patient has extremely high levels of proteinuria before the transplant, they also recommend preemptive treatment with rituximab prior to transplant. So try to lower the level of anti-PLA2R before you proceed with the kidney transplantation. So back to the KDIGO recommendations, they want us to discuss the risk of recurrence with the patient, and the risk depends on the causative antibody. So PLA2R have higher risk of recurrence, as I showed you, 80% as compared to 30% when we don't know the antigen. And the recurrence risk may be higher after living-related donation, but again, they highlight here the fact that if a live donor is available, transplantation outweigh by a lot the possible harm from disease recurrence. You can treat that, proceed with transplant. So what about the peri and post-transplant monitoring? They want us to measure proteinuria every month. And if proteinuria is 1 gram per day or higher, they want us to biopsy the kidney. If we know that the patient has PLA2R antibody-associated membranous nephropathy, they want us to measure this antibody every 1 to 3 months, depending on the pre-transplant antibody status. And while you're doing that, if the PLA2R antibody is increasing, this is a higher risk of recurrence, so consider early biopsy. And if the antibody is decreasing, that's a lower risk of recurrence. Just continue to monitor and only do a biopsy if there's a clinical indication, such as proteinuria or worsening graft function. Treatment of recurrence, as I mentioned, ACE, ARBs, and treatment of nephrotic syndrome, optimize immunosuppressants, and specifically with MMF. And if the proteinuria remains less than 1 gram, they want you to monitor because there's not a good evidence that rituximab works for this category of patient. But if your proteinuria is above the 1 gram or equal, they want you to consider rituximab, and they recommend 1 gram on day 1, followed by another gram in 2 weeks. So with all this, there are pitfalls, and I want to highlight these pitfalls. So persistence of PLA2R antibody after transplantation in the absence of proteinuria does not define relapse. I showed you a lot of patients can be PLA2R positive and never recur, and we discussed why. The disappearance of PLA2R antibody after transplantation does not exclude recurrent membranous nephropathy. In 20% of patients with recurrent disease, antibodies have disappeared. Probably this is what we call the sink mechanism. They just sink into the graft right after the transplant. PLA2R antibody can reappear many years after kidney transplantation and herald late onset of recurrence. Rituximab treatment should be guided by the level of proteinuria, not by the level of PLA2R antibody. Probably only you would look at that in the preemptive prophylaxis prior to transplantation to try to reduce the risk. But you only treat proteinurias with rituximab above or equal to 1 gram per day, then treat. There is no evidence to support rituximab therapy in patients with histological recurrence and proteinuria persistently less than 1 gram. So you can continue with supportive therapy and maximizing your maintenance immunosuppressants in those cases. I want to jump quickly to talk a little bit about the de novo post-transplant membranous nephropathy. It is relatively common, constitutes 2%. It happens in 2% of the recipients. It is especially prevalent in children. And the onset of this de novo membranous is late, usually 4 to 9 years after transplantation. It is associated with transplant glomerulopathy, suggesting an alloimmune mechanism, a chronic antibody-mediated rejection mechanism, and the presence of DSA is high in those cases. And it leads to a graft loss in close to 50%, the same graft loss rate we see with transplant glomerulopathy. So the BIEC group showed that anti-PLA2R was absent in all 9 patients with de novo membranous nephropathy. Collins and colleagues showed that anti-PLA2R is absent in 17 patients of their de novo membranous nephropathy. So this is not a PLA2R mediated disease. So PLA2R and IgG do not co-localize in the immune deposits, and I'll show you those. Transplant glomerulopathy was present in more than half of the patient. C4D staining in the peritubular capillaries was present in 13 of the 17 patients, suggesting again chronic antibody-mediated rejection. And this also further confirmed by the presence of donor-specific antibodies. And there was also mesangial deposits in 13 of the 17 patients. And the dominant IgG is an IG1 and IG3. It's not IG4. And here you can see IG1 is the dominant. Also IG3 was present. And there was no IG2 or IG4 in those de novo membranous nephropathy. So it's a completely different disease from the recurrent membranous nephropathy. This is the stain for PLA2R on those biopsies. And you can see here only the podocytes are staining. And this is the IgG, which are staining around the deposits. And when you merge, you can see the podocytes are staining for PLA2R, but not the deposit. So it's not PLA2R mediated. So can we prevent graft loss from de novo membranous nephropathy? You have to solve the problem of chronic humor rejection, which we think is the mediator, and consider a trial of anti-B cell therapy with rituximab as we do for the recurrent membranous nephropathy. I would stop here. I would thank the organizers. I would thank your attendance, and I'm happy to take any questions. And I will stop sharing.
Thank you so much again for this wonderful presentation. It was very insightful and very detailed. Uh, I'm sure the audience would also appreciate the amount of studies that you have showcased in the presentation, and also your recommendations for uh, pre and post transplant monitoring with PLA2R and other testing. So with that, we have a number of questions that have come to us, both via the chat box and some through email. I'm going to start relaying that to you one after the other in no particular order. So with that, we'll directly jump into the questions. So um, if you have to choose only one method for testing, whether would it be ELISA or IFA for PLA2R?
Yeah, in the setting of if you are to diagnose the disease, is it PLA2R related or not, you have to make every effort, to do the most sensitive tests to detect the antibody if you can. Stain the biopsy, do the IF, do the ELISA. Even here in our institution, we are so lucky. We have Larry Beck here. We can do the
Yes.
Western blots even. Like you can dig deeper and go to more sensitive techniques as much as you want if you want to define your disease, is it PLA2R mediated or not? But if you know the patient has PLA2R, this has already been defined, and you're prepping him for a transplant, we only do the ELISA test. And we know that very low levels are not going to block us from proceeding with transplant. We're not going to give any preventive therapy. They're not going to modify our approach to the transplant. So we just do the ELISA test, and we want to know the titer. And if, as I said, if it is a super high titer, and we randomly picked 150. You could pick 100. You could pick 500. There is no data. We know high titers are associated with more active disease. We know they are associated with higher risk of recurrence. So you need to know the titer, and the best way to know it is ELISA test. So if I am to pick for pre-transplant, I would pick ELISA.
Hmm. Perfect. So then the question is again similar to testing. Would you recommend that IFA testing should be done as a reflex test for those patient samples that come up negative on ELISA?
Yes, and especially if the ELISA test reads them between 2 and 14. So if they tell you 6, 7, 5, whatever, so you still like have this doubt, this could be PLA2R. And if you don't have a biopsy, you haven't yet biopsied your patient, and you want to confirm if it is PLA2R or not, I would do the more sensitive test, IFA, to kind of rules it in or rules it out.
Correct. Yeah. So according to the new KDIGO guidelines, ELISA is used as a quantitative method to measure PLA2R. But the question is, what is the advantage of the recombinant IFA test over ELISA? Is IFA also mentioned in the new guidelines?
I don't recall they mentioned it. They I don't recall honestly, but the advantages of IFA is the higher sensitivity to kind of like confirm if the disease is PLA2R mediated or not. But it's not going to be accurately quantitative as the ELISA test. So I think this is why ELISA test has been picked, because you can quantitate and you can rule in or rule out. And if you have doubts, you can further confirm with the IFA or like in-depth study by Western blot if you want.
Right. So just to also add on to your statement here, so there is some mention of IFA in the KDIGO guidelines. They alternated between the ELISA and IFA. I guess there is still more. It's more like a practice guideline, and it still needs a little bit of further understanding. But definitely appreciate your thoughts also here. The next question: should there be any genetic testing performed? I'm guessing this is, prior to doing any transplantation.
I don't think we recommend that. And, it's too hard to find a donor
Mhm.
for any person in need for kidney transplant, and to put more layers, to kind of block or make you more anxious to proceed with transplant. I think it's a bit concerning to me. So I do not recommend, if you want to do it, just to make sure you know the risks of recurrence. and be prepared, that's fine. But I would not use it to not proceed with a transplant.
Got it. Thank you so much. Then I think the question comes about the other antigens that are also there, or the other autoantibodies. So should PLA2R testing, as well as the THSD7A, both come up positive for a patient with PMN?
I didn't get the question. They both are positive?
Positive for a patient. Have you ever come across where
No, I'm
both of
not
them are
aware.
coming up
I'm
positive?
not aware of such a case. The only thing I would like to say, if you have a 7A positivity, you have to make every effort to rule out malignancies. We know it has been associated with certain malignancies like gallbladder malignancies, pancreatic, gastric. You have to make every effort to rule out malignancies. I'm not aware of a superimposed primary membranous nephropathy where we have dual 7A and PLA2R. It might exist somewhere. It might have been reported. I'm not aware of it.
Mhm. All right, thank you. So it's a very related question to it because we spoke a lot about PLA2R testing. So the question is, if PLA2R comes up negative, is it important to evaluate anti-THS-D7A marker,
Yes.
again, pre-transplant and
Yes,
transplant monitoring?
yes, yes. It's commercially available. You can test for it also, the 7A, and it's only present in probably 3% of the patient. You increase your likelihood of ruling out another 3% possible recurrent cases. You know if they exist or not. So I would try to test for other antigens if you can. But unfortunately, the rest of the list I showed you, I don't think it's available yet as a commercial test.
Right. Okay, so then you mentioned a little bit about the KDIGO guidelines. So the guidelines has talked only about PLA2R testing in monitoring of patients post-transplantation or pre-transplantation. What are your clinical recommendations when the patient is actually PLA2R negative, but it's still a case of primary membranous nephropathy? What additional testing do you conduct in your clinic?
Yeah, I honestly, the dominant antigen we try to rule out is PLA2R, and we have the ability here, to test for all the rest if we want. But if I am to do one thing, I do the 7A, and those are the only things. Patients, have undergone all the workup prior to coming to me for kidney transplant. Malignancies have been screened and ruled out, and stains have been done on the kidney biopsy showing PLA2R, let's say, or no PLA2R. So if there is no evidence of PLA2R and no evidence of 7A, I stop here.
Mhm.
I don't proceed honestly with further testing
Okay.
on a
Okay.
clinical day-to-day practice.
Mhm. All right. Thank you. So then a similar practice guideline from your perspective, what are your general practice guidelines for PLA2R testing and other kidney markers uh, prior to transplant or for post-transplant monitoring?
Yeah, the two dominant things we monitor after the transplant is the 7A and the PLA2R. If we know that the disease is PLA2R mediated, and we try to get a PLA2R prior to transplant, and if it is an extremely high level, and I said more than 150, we try to do something preemptively to get rid of the PLA2R before we proceed with the transplant if possible. And if we are to use something, we use rituximab. I would say there is no data to support that. This is our practice, and our experience have been that higher levels have higher risk of early recurrence and more severe recurrence. And then, if the level is low and we're not worried, we proceed with the transplant, and then we do monthly PLA2R after that to see in which direction the PLA2R is moving. If the PLA2R is increasing, we get alerted and we continue to monitor and be ready for a kidney biopsy if there is a more than 50 or 70% increase in the level of PLA2R, or if there's any onset of minor proteinuria. So we do protein creatinine ratio on a monthly basis on our patient in our practice, those membranous patients, and we monitor the PLA2R also. If the PLA2R is disappearing, we'll be thrilled and
Yeah.
happy, and this pretended very low risk of recurrence, less than 10%, and I think you should not worry. But you need to keep eye on that going forward because, as I said, many years down the road it could reemerge, and come back. So what should you do later on?
Mhm.
I would say probably monitor every 3 to 6 months if it has completely gone, and keep checking it as much as you can, at least every 3 to 6 months after
Right,
you prove that it completely disappeared.
right, right. Perfect. Thank you so much. So then this is another, I would say, molecular or genetic related question. Is there some relation with the ABO incompatibility with living related donor and risk of membranous nephropathy?
I'm not aware of ABO incompatibility and living related donor has come up through many studies as a major risk factors, and the reason for that is that probably they share the same genetic background that predisposed to the primary disease of the native kidneys. Probably the same genetics would continue to predispose for the recurrence of the disease, but I'm not aware of an ABO incompatibility or compatibility and risk of membranous nephropathy recurrence. I haven't come across that.
Okay, perfect. So then this is a general question that came to us is like in the US, currently, only after the KDIGO guidelines has been published, there is some level of interest in PLA2R testing pre and post transplant monitoring, whereas not many transplant centers do this testing routinely. So, just based on your webinar and your presentation, what would be the guidelines to such clinicians or laboratories who are looking into transplantations and for pre as well as post transplant monitoring?
Yeah, it's a good question, honestly. If you remember, for many years we did transplants, and on membranous patient, we had no idea what is the antigen. We had no clue, and patients recurred. Were empirically treated was whatever, either lost their kidneys or responded. So and we didn't know the antigens. But I think now we practice in an area of a precision medicine, and you have all the leverage now to kind of be prepared and ready to predict and get the patient and yourself ready and inform them about their risks. And I think it's very important if you have the ability to test for at least PLA2R, which constitutes 70 to 80% of the members' nephropathy. It makes sense to me,
Mhm.
and I can tell my patient, listen, your PLA2R is completely gone and your risk of recurrence almost inexistent. It doesn't exist. And, this is very important for the patient to know. Or I can tell him your PLA2R is present and extremely high, and you have such a high risk of recurrence 50, 80, 30, whatever. So you can inform your patients, and I think it's quite important and interesting to monitor it. Yes, you can wait for proteinuria
Mhm.
and biopsy and diagnose membranous nephropathy, but you can also monitor PLA2R and predict if you need to do a biopsy even before proteinuria occurs to show if there's any deposits. I'm not saying it's going to help you to treat, but at least it can confirm the recurrence for you and make you ready. You maximize immunosuppressants, you alter your maintenance immunosuppressant in a way to kind of get rid of this antibody if you can. So I'm in favor of monitoring. I know some places don't have the test or don't have access to this, or it's a send out to a different country or a different region. Yes, you can practice the same way you used to practice in the past, and patients will do well probably.
Mhm. Perfect. And this is one of our last questions, again, a general question that came to us via email. So, in this pandemic world, in this pandemic era with COVID-19, and since you're treating most of the patients with rituximab, how is that impacting COVID-19 patients and transplantation? Have you seen any changes? What additional testing do you do? Any guidelines or recommendations on that?
That's an excellent question. And rituximab is used not only in membranous, it is used for lymphomas, it is used for vasculitis, it is used for lupus nephritis, it is used for multiple sclerosis. If not rituximab, like the family of the anti-CD20. So yes, this is a major, major risk in the COVID area arena. So I would say, before transplant or before you proceed with the treatment of membranous nephropathy, the use of rituximab for the treatment, make every effort to vaccinate your patients for COVID and give them their boosters. Okay. And in our institution now, and I think it's a federal law, patients who get rituximab are considered tier one for prophylactic antibodies you can give, like Evusheld, for example. We give it to all our patients who receive rituximab or fresh post-transplant. They have some side effects, cardiovascular side effects. Hopefully, I haven't seen it in any single patient so far, but it has an 80-90% protection against COVID infection in those patients, vulnerable patients. Yes, this is where the utility of PLA2R could be helpful. If you detect it and it's very low level, and then make every effort to vaccinate your patient prior to transplant, that this would be an extra addition to tell them you need to be vaccinated because your disease could recur. And then you monitor after. And if you see it going away, you feel calm. You're not going to use rituximab. And if it is rising, you make every effort to boost them. Or if you need to give the booster, it can help you to kind of improve that immunity against COVID. And hopefully, if you are to use it for a recurrent disease, losing the graft is much worse than not treating because of fear of COVID. Then you make every effort to shield them with those available antibodies now that could prevent the infection. So this is what we're doing in our institution here.
Thank you so much, Dr. Francis. I think all your recommendations and guidelines would be definitely useful for the audience out there.
Thank
So,
you.
with that, we come to the end of this session. Thank you so much once again for this wonderful presentation.
My pleasure.
We truly appreciate it.
Thank
So,
you.
for the audience, in case you're interested in PACE credits for this webinar, so I have pinned the link for PACE credits where you can go and claim your credits and certificates. We will be hosting our finale episode for the autoimmune nephrology series next month on April 21st with Bernie Collins from Massachusetts General Hospital, who will be talking a little bit more on the laboratory testing for detecting various autoantibodies in primary membranous nephropathy. So with that, I would like to thank all of you for attending this webinar. Once again, thank you, Dr. Francis. We truly
Thank you so
appreciate
much.
it. All
Have
right.
a great
Take
day.
care, everyone. Bye-bye.
Bye bye.